patients. Now it is my pleasure to invite Dr. SAVIO Pereira, who is a senior consultant and director of the fellowship programs, FACO fellowship programs at Netradama Super Specialty Eye Hospital, and he'll be talking on the surgical evaluation and then pre-op workup for premium IOLs. This is very important because today patients are very demanding and they don't want to wear glasses after cataract surgery. So over to Dr. Savio.
So the surgical evaluation and preoperative workup for premium IOLs, you've done your biometry right, and the most important thing for the preoperative workup, I would say, is that get to know your patient. Understand what are his hobbies, the interests, and what are their expectations. And in today's world, you have to give each and every patient the option of being glasses free, because we cannot say that, okay, they may not need glasses, and don't try to complicate options. It's very simple. You have astigmatism, you need a toric lens. If you are an active driver and you don't want glare and halos, you have the extended depth or the enhanced monofocals, and definitely you have the trifocals and the multifocals. So it's very important that you give these options to your patients. And one of the most important things, they will come and ask you as a surgeon, will I still need to wear glasses? Will I be able to drive at night? Is it reversible? You will get these questions, and you have to answer each and every one of them, because your patient will be very unhappy if you have promised something and not delivering. So as a surgeon, you can share your experience with different lenses. If you have a patient who has Parkinson's, who can't wear glasses, but at the same time has glaucomatous optic atrophy, putting a trifocal doesn't make any sense. You have to see the risk and benefits in each and every case, and where you individualize your IOLs. You may have got your biometry right, but at the end of the day, which patient is suitable for which, you are the best judge in your experience. For the patient, they don't know that. So what you need to understand is, most of the patients are undergoing some form of laser vision correction, and they want to continue that and be glasses free. And the type of IOL depends on the quality of the vision for the rest of their life. So this is something which is very important. Now sometimes you'll have a patient who has got a monofocal in one eye and says, I want to be glasses free. If you put a trifocal in the other eye, the contrast and the glare halos, it will not be tolerable. In this case, an EDOF or an enhanced monofocal will be much more better, or giving them a mix and match option is much more appreciable. At the same time, expected that the patient will have a good outcome. At the same time, try to get a continuous range of vision. So we know we have the distant, we have the intermediate, near intermediate, and the close reading. See what the patient already has before and try to follow it up with the remaining eye by checking the dominance, checking the tolerance. This is where you can individualize and customize the treatment for the patients. Coming to torics, just a small thing is that even in patients with keratoconus, pellucid marginal degeneration, post-keratoplasty, it will all be covered up. You should see if they are suitable for torics, and this is something with the EKR formula where you can see if there is a lovely peak, that patient is definitely going to be very happy, while if it's a flattened out peak, they're not going to be happy with your toric lenses. Some of the contraindications, you have to break the bad news. If the patient has a bad pseudoexfoliation, subluxated lens, you have to tell them that you are not suitable for a trifocal lens. You're not going to be suitable, you're not going to be happy. Coming to angle alpha and angle kappa, I would say you should know this, especially in a premium IOL practice. If the angle is above 0.5, especially in the angle alpha, kappa is more for refractive surgery because the laser is fixed to the pupil, the laser tracking system, while angle alpha is the center, at the nodal point of the eye, while kappa is the pupillary center. So if you have an angle larger than 0.5, your patient is not going to be happy because the centration of the lens will be off. This is something very interesting. You have aberrometers now to your disposal. Remember here, the total always includes the internal and the cornea. And here you can see the cornea has not much, but the internal is contributing, and that is why you can have higher astigmatism. So this patient doesn't need a toric lens at all. And you can come to know the higher order abrasions from your aberrometers. You can know the aspericity, whether you are going to put an aspheric lens or a spherical lens and add to the spherical abrasions. Now, most of the lenses, being even premium monofocals, will say we have a plus 0.27 or a plus 1.8 or a neutral spherical aberration lens or aspheric lens. Depending on what type of the previous abrasions are existing in the cornea, you can adjust that and preserve that. If the patient has got a presbyon or a laser blended vision, you want to preserve that. Now, there are some few challenges in the very large axial length eyes. What do? You are not going to get lenses, be it trifocals or read-offs, beyond a certain power. And if you have single digit lenses, most of us are aware that beyond 6 diopters, only you get the trifocal lenses, or sometimes only beyond 10. So you need to be a little careful which type of lens. The same thing in the very short axial length eyes. You have difficulty in the calculating the ELP. So what do? In these cases, you can definitely think of going for a monovision. This has already been covered, so I won't go into depth. This is an interesting case of a patient who had undergone 15 years back of an ICL implantation and LASIK, that was bioptics, 18 years back. And just to give you an example, if you miss out one thing, and you just do the IOL power calculation, you can see there's not much difference in the axial length between the two eyes. But by just putting the LASIK, that is the laser vision correction mode, the IOL power for the same lens changes from +0 to +2.5. So this is something, what you should do is get the biometry when the patient comes to you, and you can counsel your patient along with the biometry and say these lenses are suitable, these lenses are not suitable. And always, for the tough cases, do the biometry yourself. Just giving you an example, this is a patient who had decreased vision or very high hyperope. You're not going to get your readouts or trifocals for these powers. So then monovision does work well in this. You can find out the dominant eye and the non-dominant eye and then go ahead and see. So here you can see the axial length is very shallow and the ACD is shallow. At the same time, you have so much variation in the IOL powers. You can see 46, 42 with the SRKT, 47, 46.5. There's so much of variation, and that's the time when you can do a multi-formular approach and then rationalize and go. So we did a monovision in this patient, and as you can see at post-op, the patient was very happy. So coming to the summary, always counsel your patients for glasses independence. Sometimes you may need to go for customized IOLs if the IOLs are not available. Micro monovision does work well, especially if the IOL powers are not available. Be careful in post-refractive surgery eyes. Do a multi-formular approach, check the refraction in the other eye, and always under-promise and over-deliver in complicated cases. The straightforward cases are always good, but the complicated cases will trouble you. Thank you very much.